Hey guys, today we're going to do the first part of perfusion, and that is hypertensive crisis and valvular disease. So for hypertensive crisis, we really only have one slide about it. It's not too intense, right? But we just have to figure out what the difference between hypertensive emergency and hypertensive urgency. So for hypertensive crisis, the actual definition is any blood pressure over 180 systolic and or 120 diastolic. Right? So you can have one or the other of both. Right? So that means hypertensive crisis. Now the question for treatment is it emergent or urgent? Right? So the things that would make a hypertensive urgency are anything that would have impending organ damage. Okay, so think things like heart attack, high-risk pregnancy, aortic aneurysm dissection. Okay, so any of those may have end organ damage, and that would equal a hypertensive emergency. Versus hypertensive urgency, there's no impending organ damage. Right? So the difference for urgency versus an urgency or emergency is also going to include the treatment. Right? So for hypertensive emergency, we're going to use some IV medications, usually medications like nicardipine, okay, or the brand name of Cardine, right, and that's going to help lower that blood pressure decently quick, right, but we don't want to lower it too much because it can actually cause things like stroke. So there's a nice guideline for lowering blood pressure for the hypertensive emergencies. Right, so instead of looking at that systolic and diastolic when treating it, we're going to look at the MAP, okay, that mean arterial pressure. So the MAP lowering goal for hypertensive emergency is 20 to 25% within the first hour of treatment. Okay? So depending on the physician and the patient, usually you're going to get a goal pressure. Example would be like 160 over 100 for the first 6 hours, and then gradually decreasing over amount of days. Right? So again, for that hypertensive emergency, we don't want to just drop it from 200 to 100 because that person's going to end up with all kinds of like organ failure and strokes. So they're going to go on that lowering goal to lower that MAP of 20 to 25% within that first hour, and then gradually lower it for hours to days. Okay, so that's emergency. So for hypertensive urgency, we're going to use oral medications to help reduce our pressure, and it's going to usually be over 12 to 24 hours. Okay. People with the highest risk, usually this happens when patients stop taking their hypertensive meds, or sometimes their hypertension will go undiagnosed for a long time, and then they find themselves in trouble. Alright, see, I told you, hypertensive crisis is very, very quick. Right. So, on to valvular disease. So for valvular disease, we have 3 different types, right? And valvular disease really is just when heart valves don't open or close properly due to blood flow being affected. Right? So there's 3 different ways that we can affect blood flow, or that valvular disease affects blood flow, and that's regurgitation, stenosis, and prolapse. Right? So regurgitation is a backflow of the blood through the valve, versus stenosis is like a narrowing of your vessel, or the hardening of the vessel, and prolapse is the stretching of a valve leaflet. Right? So regurgitation and stenosis can affect all our heart valves, but prolapse really can only affect the mitral valve. Right? So again, regurgitation is that backflow of blood, stenosis the narrowing of the vessels, prolapse is the stretching, and prolapse can really only affect the valve, or the mitral valve, versus regurgitation and stenosis can affect all of them. Right? When we talk about each one, we're going to talk about a few different ones, you're going to see that they kind of sound the same. All right. So let's first talk about mitral prolapse. So what is mitral prolapse? This is when one or both of the mitral valves balloons back into the atrium during systole. Right? So remember, when you talk about prolapse, we're thinking stretching of that valve. So now we have a nice stretched valve, and now it's going to balloon back into our atrium during systole. So when this happens, we're going to have symptoms like fatigue or dizziness, if there are any. Usually there's not really any symptoms, right? But you might hear something called a mitral click, and that mitral click is an extra heart sound, and it's usually the way that that's assessed or that it's found. Mitral valve prolapse can also be found with an echo, right? And who's at the highest risk is women, and we don't really know why, but you see it a lot after pregnancy. So our responsibility as nurses for mitral valve prolapse is making sure that patients get checked out, so with echoes, or they might have, if they have a first-degree relative that has mitral valve prolapse, we want to tell them to go and get their heart checked out because it can be genetic. Right? We also need to tell them to have that heart-healthy diet and exercise. So in mitral regurgitation, remember regurgitation meaning that backflow. This is when we have blood that backflows from the left ventricle to the left atrium during systole. Okay, so again, mitral regurgitation, backflow of blood from the left ventricle into the left atrium during systole. Okay, so when this happens, our lungs become congested, and that can actually have strain on the right ventricle, leading to what looks like heart failure. So for people with mitral regurgitation, you might see symptoms of congestive heart failure. So lower extremity edema, crackles in the lungs, cough, right? Weight gain. So these are things that you're going to see with mitral regurgitation, all because of that right ventricle being strained. Right. So who's at highest risk for this? Anyone who's had rheumatic heart fever, endocarditis. Right, and actually rheumatic heart fever and endocarditis are risk factors for any of the valvular diseases. Right. You also might see this with people with cardiomegaly, sorry. Right. And how do we assess it? Right. So again, they can have an echo, but instead of having a mitral click like the mitral prolapse, you're going to hear a high-pitched systolic murmur. Right. Typically our responsibility, again, besides cardiac education, is going to be basically treating heart failure. So you might have an ACE or an ARB to reduce afterload. They might be on oxygen to reduce workload. You might see them on fluid restriction and diuretics. Okay, so typical CHF treatment. Okay, so now let's talk about mitral stenosis. Right, so remember, stenosis is the narrowing of the vessel. So in mitral stenosis, we have an obstructed blood flow from the left atrium to the left ventricle. Right? So this obstructed blood flow from the left atrium to the left ventricle. So this is going to lead to poor ventricular filling, and that can lead to decreased cardiac output. You're going to end up having some increased blood volume in the left atrium, leading to some hypertrophy. And then this can lead to pulmonary congestion. Right? So you're going to have an enlarged atrium. You're going to have pressure on the bronchial tree. So instead of seeing things like congestive heart failure for mitral stenosis, you're going to see things that almost resemble things like asthma and bronchitis. So cough, okay, respiratory infections, okay? So anything like that. So who's at the highest risk? Obviously those rheumatic fever, right? And endocarditis. Like I said, they're pretty much the risk factors for all of these. And we can assess this. We might see irregular pulse with AFib. They might have a low-pitched rumbling diastolic murmur. And you are going to be able to see it with an echo and EKG with these guys. Right. So nurse's responsibility for this, we're going to do a heart-healthy diet, right? Try to avoid anything that could increase the heart rate, any strenuous activity, and that includes pregnancy. So now let's move on to a different valve. Right? So now we have aortic regurgitation. Okay, regurgitation meaning backflow. So now we have flow of the blood back into the left ventricle from the aorta during diastole. Right? So backflow of blood into the left ventricle from the aorta during diastole. So who's at the highest risk? Okay. Rheumatic fever, endocarditis. These people obviously can, they might have blunt trauma to the chest causing this. They can have dissecting aorta, right? And sometimes it can be congenital. Right? So how are we going to assess this? Right? You might see a wide impulse pressure with these patients. You're going to hear a high-pitched diastolic murmur. And then you can also see it on things like a transesophageal echo. You might even find aortic regurgitation with things like cardiac cath. And our responsibility for these patients is, again, education, heart healthy, anything that would strain the heart. They might going to do some isometric exercises. But we're also going to tell these people to get an echo every 6 months because we really want to keep an eye on it. Regurgitation of such a large vessel could be very, very hazardous. Finally, we're going to talk about aortic stenosis. It's, remember, stenosis meaning that narrowing of the vessel. Right? So now we're going to be obstructing blood flow from anywhere into the aorta. So, again, obstructing the blood flow between aorta and the ventricle, right? The left ventricle. So who's at highest risk? Well, we're going to have anyone with any chronic disease. So that could be diabetes, high cholesterol, hypertension, again, can be congenital, and of course rheumatic fever and endocarditis. Right? So how are we going to see, what are we going to see? Again, you can find this just like any other valve disease with an echo. This one might show some changes on EKG too, but you're going to hear probably an S4 sound and possibly a low-pitched vibrating systolic murmur. Okay? So usually you're going to hear a systolic murmur over the aortic area, but it can actually radiate to the carotid arteries depending on the amount of stenosis. And our responsibility, controlling those risk factors. Right? So stop smoking, control your diabetes, control your hypertension, okay? Cardiac healthy stuff. So valvular disorders, let's nursing process it out. Right? Assessment, again, depending on what kind it is. Mitral valve prolapse often won't have any symptoms, but if they do, you might see some fatigue, dizziness. Right? Aortic regurgitation, mitral regurgitation, we're going to see signs and symptoms of what looks like heart failure. Mitral stenosis, you might see things that look like respiratory infections, asthma. In our aortic regurgitation, you're going to see some widening pulse pressure. And for aortic stenosis, well, that could be asymptomatic too. They might have some dysrhythmias and definitely those changes on that EKG. Nursing diagnoses for any valvular disorders include decreased cardiac output, can include activity intolerance, right? Anxiety, right? And of course planning and interventions for nursing is going to be that education. The people that need to go have echoes, first-line relatives, right? Heart-healthy medications, definitely referrals to cardiologists because they're going to keep track of this, and making sure that they know what medications they need to take. Right? An evaluation, making sure they've decreased those risk factors. Did they stop smoking? Right? Did they get their diabetes under control? And so all of these things we can do to evaluate valvular disorders. And that is all I have for Perfusion Part 1, so I will see you guys for the next one.